Good morning everyone. I'm Sushmitha Priyadarshini. Today's my presentation topic is management of children with hearing impairment. Hearing impairment is a full or partial decrease in the ability to detect or understand sounds. Hearing loss can be a congenital, that is during birth, or developmental during childhood or adulthood. And children cannot express well that they can't hear well, hence it is a hidden disability in children. Um, if hearing loss is not detected or treated, can lead to many problems such as delayed speech and language development, social and emotional problems, and academic failure. Hence, early identification and intervention plays major role here to help the child in developing speech language skills. And also listening skills, social skills, and performing well in academics, etc. Auditory rehabilitation refers to a remedial efforts with children having hearing loss since birth, who doesn't acquire communication skills since birth due to hearing loss, and since there is nothing to restore, which has never existed before, has to take further rehabilitation steps such as identification of hearing loss, like how do you identify, and parent teachers roles are very important in identifying children's speech and language problems, and at what age is identified. Identify comes once it is identified, intervention is has to be taken soon. And once identified, get your child for audiological evaluations based on tests. Your audiologist may plan for further um, uh, treatment such as like cochlear implant, hearing aid, assistive listening devices. Once the amplification is done, the child has to sign in for therapy sessions without fail, in order to practice listening skills, listening to sounds, understand it, and to respond, speak. So this helps in speech development and language development. Hence, parental guidance is very important to understand what their child needs and their to meet their expectations. So the next step is early intervention. As discussed earlier, early intervention is important because child develops speech usually at first 2 years, which is critical age. At this point, if child is not getting proper speech stimulation, it's affecting development of speech and language, which is next step to be focused on. Is communication skill development. Once speech language and auditory development starts, the child start developing literacy development like cognition, writing, and reading. For many children, systematic introduction to the sounds during the early years uh, will have a positive impact on language learning. Effective stimulation of residual hearing is critical to the development of speech and spoken communication. So the criteria for selection of different listening programs is based on the training of the hearing impaired, is always confined to the effective use of amplification and improvement of auditory and visual communication, and the professionals also deal it broadly. Hence, there is need to consider a case management model depending upon the client's level of function, like everyday environment, what kind of communication demands they face in their surrounding, and how they overcome or not. So the basic criteria includes age of hearing impaired individual, degree of hearing loss, listening level of the child, age at which hearing aid or implant is fitted, associated problems, and baseline of the child. So the amplification options such as hearing aids or educational amplification units are most important tool to overcome hearing disability, to help hearing impaired person. And restoring hearing is impossible, hence amplification system uses residual hearing and amplifies the signal accordingly. Amplification system includes hearing aids. There are many types of hearing aids, such as the receiver in the canal, behind the ear, in the ear, in the canal, and invisibly in the canal, and completely in the canal. And implantable devices such as cochlear implants, bone anchored hearing aids, middle ear implants, auditory brainstem implants, auditory midbrain implants, etc. Group amplification devices such as hardware induction loop, FM system, infrared system, etc. So the conventional hearing aid, here the concern is, as in case with adults, when fitting, decisions must be made about the type or style of hearing aids. The cosmetic plays a major role when adults are fitted, same as in younger children. Hence, the attempt should be made to reduce these concerns on the part of child and parents, so that appropriate amplification is the primary basis on which the decision of hearing aid type is made. So the nowadays hearing aids are even behind the ear. Hearing aids have lots of options such as Bluetooth connectivity, rechargeable options, and ear mold options, color options. In rechargeable options, which is sufficient, having power and flexibility to fit most hearing losses, and easy to adjust in apps, in apps by themselves. So for children who are using behind the ear hearing aids, and who requires extremely high gain, and having feedback problems, ear molds must be well designed to reduce the feedback problems, and also to increase maximum gain output. And there are soft molds which helps to reduce the risk of injury if child falls or it is struck in her head, especially with ear level ear aids. Frequent replacements of ear molds are necessary to maintain adequate gain, and ear mold adequacy is necessary. Non-hearing aid assistive listening devices for children. Hearing impaired children, especially those with more serious losses, should not be confined to conventional wearable amplifications. Systems used in the classroom and other designed for personal use and generally classified as assistive listening devices. Assistive listening devices are designed to improve signal to noise ratio and reduce effects of reverberation by moving a system's microphone closer to the person who is speaking. These assistive listening devices such as FM receivers, which uses conventional amplifier to amplifies the voice while still maintaining favorable SNR for the primary signal, and induction loop sends electromagnetic signal from the person speaking to the child's hearing aid. And this TV units, telephone messages like phone clips, uses telephone amplifiers, and it picks up the TV unit picks up the TV audio, and it sends it to the child's amplification devices directly, using the hardwire, FM, or induction loop. So these arrangements avoid amplifications or room noises. Moving on to next system, that is cochlear implant system. A cochlear implant is a technologically advanced medical device that helps adults or children who is having bilateral severe to profound hearing loss, and they are not receiving benefit from hearing aids or tactile devices to understand speech. So the cochlear implant is a device that can restore to partial hearing and speech ability to individuals with sensory neural deafness. And in cochlear implant there are two parts. The internal part is an implant that is surgically implanted inside the in the temporal bone of the ear, and the other part is externally placed the outside external as a external hearing aid, that is called as a processor. The cochlear implant differs from the hearing aid in that it does not amplify sound. Rather, the cochlear implant is a device that bypasses the damaged hair cell in the inner ear and converts sound vibrations into electronic impulses that are received by the auditory nerve and transmits to the brain. So the both adults and adults who have lost their hearing later in life, and young children who are benefiting from cochlear implants. So therefore the cochlear implants are surgical implanted electronic devices coupled to external components, provides useful hearing, provides communication in children and adults with severe to profound hearing loss. So there are two kinds of approaches, unisensory and multisensory, in rehabilitation of hearing impairment children. One is unisensory approach. This is a training that is given to the individuals with hearing impairment using only one sense. So the most important sense is auditory, and in multi-sensory approaches, all three senses can be used, auditory, visual and tactile, in combinations as well. Acoustic informations got through each of the senses. Our auditory senses such as acoustic parameters are perceived the best. Acoustic parameters such as time, quality of the sound, pitch of the sound and loudness of the sound, and place and manner of articulation cues are well perceived, like bilabials, fricatives, etc., etc. Distant sense, suprasegmentals are perceived easily and localization is easy. In visual cues, place of articulation is better perceived than the manner of articulation. Place of articulation is peripheral sounds are easy, like bilabials and labials, labiodental, etc. Indirect cue on intensity from facial expression. Um the loudness varies according to the facial expressions given, and suprasegmentals are vaguely perceived. Stress by duration is perceived. Distant sense is perceived, but it is affected by some barriers in between. Localization only if the source is in visual field. If it is backside, if it is out of the visual field, it's difficult to perceive it. Tactile cues, like frequency, intensity and duration cues are too small to extend. Manner of articulation cues and are perceived, and no place of articulation is perceived. Distance sense is not understood. Only the near sense can be felt by the individuals, and distant sense if devices are used, like tactile devices, the vibrators, like that. If they feel, if someone knocks and which is connected to these tactile devices, when someone knocks, it will be perceived through the tactile sense. Pitch variations can be perceived, and durational informations like short or long duration, etc. Uh, the auditory training, the child who is trained to use his residual hearing to the fullest extent develops a better understanding of the relationship between sounds and objects, sounds and actions, sounds and people, and he begins to associate the sounds of speech with the language he has learned. So this leads to better speech and more comprehensive grasp of language. So the traditionally auditory training has been considered a major component of the audiological rehabilitation process, and the most traditional approaches to auditory rehabilitation, auditory training, use hierarchy for auditory skills developments. So this hierarchy includes awareness, discrimination, identification and comprehension. Carhart in 1960, he has defined auditory training as the process of teaching the child or adult with hearing impairment to take full advantage of available auditory cues, and this result in therapy on this results on developing an awareness of sound, gross discrimination of non-verbal stimuli, gross and fine discrimination of speech. Guidelines suggest that the training stimuli should become more challenging to discriminate over time. A variety of talkers should speak training items. Many training items should be presented during a relatively short of time. Non-speech training stimuli should be used only with the young students who are prelingually deaf and only for a short period. So this auditory training exercise can include both analytic and synthetic level stimuli. Training progresses from closed set to open set response modes. 10 to 15 minutes a day should be devoted to formal auditory training, preferably at the same time every day. Formal training objectives should be pursued informally throughout the day. Training activities must be engaging and interesting. So the different programs are approaches of auditory training. In 1802, ITAD devised specific training procedures to develop auditory awareness and discrimination and systematically observe the effects of these methods. So he utilized a variety of sound stimuli beginning with a church bell. After a year of training, two of his six clients achieved word intelligibility. Kelly in 1954 and 1974 conducted 6 weeks remedial programs for hard of hearing children, which included daily auditory training. Auditory stimuli were presented, children responded, and the clinician or other children provided the feedback on the correctness of the response. In addition, the discrimination training between the error choice and the correct stimuli was presented. The stimulus begin with number sequences, progresses to letter sequences and to words, and finally advance to messages. Wedenberg's approach, Wedenberg 1951, it is an early approach to auditory training used with children with severe to profound hearing loss. It was first described by Wedenberg. His training also served to exploit whatever residual hearing a child possesses. His approach was eventually labeled as unisensory since he advocated that speech reading should not be consciously emphasized until the child developed a proper listening attitude. His program was directed towards increasing the child's attention to the sound. Both environmental and speech sounds were used in the early stages, which he referred to as ad-conc-hum amplification. This involved speaking directly into the child's ear at a close range, that is half inches, rather than the child used hearing aids. Exercise which helped the child become aware of and attend to sound at increasing distances were used. These included in presentation, in isolation, walls, and voiced consonants whose formants were thought to be within child's audible range. Syllables were used in variety of formal therapeutic activities such as as well as informal settings at home. Combining individual vowels and consonants learned in isolation resulted in perception of a limited number of words. At this time, Wedenberg advocate part-time use of hearing aid. Later, training progresses to short sentences formed by words already recognized by the child acoustically. Although not given direct focus, speech reading could be used as a supplement. His method was directed towards development of auditory, speech and language skills in children with either a congenital or prelinguistic hearing loss or severe to profound hearing loss. Next approach is verbotonal. It's effective for establishing good spoken language and listening skills, and based on developmental model of normal hearing children, emphasizes the importance of developing good rhythm, intonation and voice quality in hearing impaired children. Specifically, trained teachers, clinicians are combined with high quality amplification and vibrotactile input with system universal, verbo and auditional Guberina units. These units provide a wide frequency response with the option of modifying the frequency response through the cutoff frequency and slopes of filters to emphasize the optimal field of hearing of each hearing impaired child. Through intensive intervention, the rhythm and intonation patterns and the listening skills develop simultaneously. The goal is to integrate hearing impaired children into regular educational and social situations. The integration rates are between 60 and 90%. The parents' role is more supportive than therapeutic and is designed to meet the needs and skills of each parent. Next is acupedic approach. It is unisensory approach given by Doreen Pollack in 1952. This term acu refers to acoustic and PD refers to pediatrics. This approach is not only to teach listening skills but also teaches languages. Doreen Pollack has described the prerequisites and steps to be carried out, such as early identification of hearing impairment, preferably by first birthday, fitting binaural ear devices, training through one modality, that is auditory modality, normal contact with the environment, prolonged systematic training which is intensive. This kind of training can be given to children who even have a profound hearing loss. According to them, children up till 5 years can be given the training, but not above 7 years of age. So Pollack has mentioned the following steps to be taken in order to carry out the method. First is auditory training, awareness of sounds, initially loud sounds and later softer sounds, attending to sounds, responding to sounds, localization, discrimination between sounds, developing feedback mechanism. Second is do not use speech reading or lip reading. Reason she recommends this that I cannot detect rhythm and other suprasegmental aspects of speech. I does not provide adequate feedback about the way person produces speech himself or herself, and people who speech read or are much tensed because the person has to strain a lot of speech read. Proprioceptive feedback cannot replace auditory feedback. One get feedback about position, movement, etc. So third is using normal speech patterns, and everything should be taught meaningfully. Language develops through imitation. Articulation is taught later on. All of this training are through individualized training program and not in group session. Advantages of acupedic approach. Children learn to use their auditory mechanism to their maximum. Hence they learn vocabulary and language more easily. Voice quality of person is much better and articulations tends to get better. Children who learn speech and language earlier would be able to integrate with others and then find employment later. Next is the Cahart program given by Cahart in 1947. This method was first a systematic approach in auditory training for children with hearing impairment. It is based on the belief that since listening skills is normally learned early in life, the child processing a serious hearing loss at birth or soon after will not move through the normal developmental stages important in acquiring these skills. So it has 4 stages. One is sound awareness, that is to recognize sound is present or not, and the child should be surrounded with sounds that are related to daily activities and that are clearly audible. Next is ground sound discrimination. Initially involves demonstrating with various noisemakers that sounds differ, and training at this level involves discrimination of several parameters of sound such as intensity, duration, etc. Third is broad discrimination among simple speech patterns. The child is aware that the sound differs, and this knowledge should also apply to the understanding of speech. A familiar, meaningful phrase that is sufficiently different to minimize confusion is used. Next is fine discrimination for speech. It includes repeated drills of speech stimuli in connected discourse and integrated and increased vocabulary to enable him or her to follow connected speech in a more rapid and accurate fashion. Carhart also felt the use of vision by the child should be encouraged in most auditory training activities. Next is ASP developmental program. It is a 6-level program developed by ASP and co-workers to facilitate the development of auditory and language competences among children with hearing impairment. During the first stage, child is encouraged to vocalize, and this is monitored by tactile kinesthetic feedback, and no attempt is made to alter this output, but multisensory stimulation is provided along with this. So the second level utilizes audition as the primary reinforce of his vocal output. The teacher imitates the child's babbling in such a way that he provides a model for expanding and lengthening prosodic patterns. So the child's vocalizations or verbalizations are accepted with little or minimal correction. Third level is when the child incorporates word into his vocal play. So during the fourth level, remediation focuses on the remaining errors in perception and production of speech prosody and rhythm. So emphasis is also placed upon increasing the auditory memory span beyond 3 or 4 elements. The child is instructed to imitate rhythmic stimuli like tap 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 my nose, tap 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 my toe, etc. The voice achieved during this stage should be normal or close to it. The fifth level is attained when phonemes of all pitches included in speech and voice and prosody are almost normal. The auditory memory span is between 4 and 6 units in length. Uh, Spoken language is spontaneous and includes questions and statements. During sixth level, the perceptual training focuses upon phonemes at highest pitches and auditory memory span. The child is learning linguistic structure through auditory input. Upon the completion of the sixth level of ASP, the hearing impaired child is integrated into regular public school, but they receives therapy 3 times a week. Eighth one is Miami Chad's curriculum. Here the Miami Cochlear Implant, Auditory and Tactile Skill curriculum is a comprehensive manual for training deaf and hard of hearing children in the use of sensory aids for speech perception and production. It includes a hierarchy of goals and objectives that provides a framework for teaching a variety of receptive and expressive skills. So each objective is accompanied by one or more sample activities to assist the user in developing targeted skills. So over 100 activities are described in an easy to follow format. Early hearing detection and intervention program. Here it is located in states and territories and are designed to identify infants with hearing loss. Infants identified with hearing loss can then be enrolled in an early intervention program. So early intervention programs are designed to help infants and children develop communication skills needed to do well academically and socially. Communication skills can be learned through visual, spoken language or both. So the next is auditory rhythmic training. In this program, children should be aided appropriately. It focuses on importance of rhythm and the rhythmic elements of language in auditory perception. It has 3 stages. At all stages, close reference is made to available audiological information, and this is used in planning the activities for individual children. Sound levels are closely monitored and information about children's responses are shared with the audiologist. Parent and child work closely together as activities focus not only on physical and rhythmic movement to sound and music, but also on reinforcing early communication skills and listening behaviors in keeping with Eber's progression of auditory skills. So the stage 1 refers as within stage 1, 3, 1 there are 2 groups. So under 3 to 4.5 years old, In the early days of stage 1, it is very much parent child partnership, and initially when a child cannot move rhythmically by himself, the parent does the moving for and with him, helping him to understand the rhythmical activities. So the aim of the stage 1 are to develop awareness of sound, leading on to the development of auditory detection and discrimination. And next is to achieve good eye contact and visual attention, and to develop anticipation, to encourage awareness of others and turn taking, leading to group cooperation and participation, to experience and develop rhythm. So early activities may include movement to music like slow swaying or lively bouncing on the parent's knee, responding to sound, example like playing bass, passing the ball, action rhymes, etc. Stage 2, in this stage does not generally have parental involvement in the session. The additional aims in stage 2 apart from stage 1 are improving breathing and breath control, developing auditory memory and sequencing, refining discriminatory abilities. So the rhythm curve is introduced in the written form for the first time, initially on the children's own names, the rhymes of which they would already recognize. So the activities are grouped into non-verbal rhythmic movement, example rowing to music, rhythmic language activity like nursery rhymes and action songs, singing, listening and discrimination, example like musical chair, find the source of the sound, and breathing, example like car game, children sing a tone to keep their car going along a track. Stage 3, it emphasizes lies in the rhythm curve, and its use in enhancing language skills and also in listening for comprehension. Each training sessions last for 40 minutes and will contain 4 basic parts: a rhythmic activity, musical discrimination activity, language rhythm curve work, a listening activity. Children match rhythm curves to the language and create language to match rhythm curve patterns. Next approach is SPICE. Moog et al. 1995 developed the speech perception instructional curriculum and evaluation, that is SPICE, to provide a guide for clinicians in evaluating and developing auditory skills in children with severe to profound hearing loss. It contains goals and objectives associated with 4 levels of speech perception. So they are, the first level is detection, is intended to establish an awareness and responsiveness to speech. So the second and third levels are suprasegmental and vowel and consonantal perception are worked on. In suprasegmental section, children work on differentiating speech based on gross variations in duration, stress and intonation. In the vowel and consonant section, children begin to make perceptual distinctions among individual word stimuli with similar duration, stress and intonation features, but with different vowels and consonants. So with progress, the child is introduced to the 4th level, that is connected speech. Now the emphasis is the perception of words in more natural environment, phrases and sentences. Activities for SPICE are done with combined auditory visual presentation as well as auditory only listening situation. As the child progresses, the newly acquired skills can be refined further in more natural, informal conversation. So recently the SPICE has been used extensively with children using cochlear implants as an approach to developing listening skills in conjunction with their expanded auditory input. Methods of auditory training. According to Blarney and Alcantara 1994, it is possible to categorize them into one of 4 general categories based on the fundamental strategies stressed in therapy. So one is analytic, attempts to break speech into smaller components like syllables or phonemes, and incorporate these separately into auditory training exercises. So examples include exercises that emphasize same different discrimination of vowel or consonant phonemes in syllables or words, or require the listener to identify a word within a closed set response format. Example, run, money. Analytic training employs bottom-up tactics. This implies that perception, hearing, influences cognition. Synthetic training refers to training based on recognition of the overall meaning of discourse, emphasizes a more global approach to speech perception, stressing the use of clues derived from the syntax and context of spoken message to derive understanding. So it does not require awareness, identification or comprehension of every single small segment of the speech signal. Instead, it focuses on communication strategies and top-down processing. This is based on the concept that cognition influences perception. Training synthetically involves the use of meaningful stimuli, words, phrases, sentences. This might involve practicing sentence perception based on prior information about context. Example, having lunch, a classroom discussion on government, or having the clinician name a topic and present related words or phrases that the individual must repeat it back. In pragmatic, it involves training the listener to control communication variables such as the level of speech, the signal to noise ratio and the context or complexity of the message in order to obtain the necessary information via audition for understanding to occur. For example, the person with hearing impairment practices how to effectively use conversation repair strategies like asking questions or requesting that a statement be repeated or clarified to comprehend a paragraph read by the clinician. Next is eclectic, which involves training that combines most or all of the strategies previously described. While the auditory training programs to be described all have analytic, synthetic or pragmatic tendencies, most would best be described as eclectic. Since more than one general strategy for the training of listening skills typically is used with a given child or adult. So next is auditory verbal therapy. It is an approach for earlier intervention for the deaf and hard of hearing children and families. It focuses on education, guidance, advocacy, family support and the rigorous implementation of techniques, strategies, conditions and procedures which promotes effective use of listening. The goal of AVT is that the children who are deaf can grow up in regular learning and living environment, enabling them to become independent, participating and contributing citizens in mainstream society. So rationale supporting AVT, there is always some residual hearing in children who are deaf and hard of hearing. If the amplification is provided sufficiently, children who are deaf and hard of hearing can detect speech. So when fitted properly with amplification, the children need to be visual learner. So effective use of critical period should be done to see benefit in child. If the identification is not done during this time, the child's ability to learn will deteriorate. The principle is to promote early diagnosis of hearing loss in newborn infants, toddlers and children, followed by immediate audiologic management and AVT. It's recommended immediate assessment and use of appropriate state-of-the-art hearing technology to obtain maximum benefits of auditory stimulation. And it promotes detection of hearing loss as it believes prolonged auditory deprivation during early life of child will create significant delays in expressive and receptive language development. After identification of the hearing loss and assessment, the child must be fitted with appropriate amplification devices. which ensures listening to the environment sounds, and these sounds should go to brain. Guide and coach parents to help their child use hearing as the primary sensory modality in developing listening and spoken language. And that is like hearing loss will have major effect on the family members, and they are crucial for success. There should be active participation, and the child learns from parents and family. The parents should counsel to use listening and spoken communication, and hence encourage the child. Guide and coach parents to become the primary facilitators of their child's listening and spoken language development through active, consistent participation in individualized auditory verbal therapy. The AVT is delivered one-to-one to maximize individual development, and it provides greater attention to the uniqueness of the child and parents. Guide and coach parents to create environments that support listening for the acquisition of spoken language throughout the child's daily activities. The ideal listening environment will make listening easy as possible to the child. So the guide and coach parents to help the child integrate listening and spoken language into all aspects of the child's life. The parents should associate auditory experience in meaningful ways. Values listening, the child will do the same. Guide and coach parents to use natural developmental patterns of audition, speech, language, cognition, and communication. The parents are guided to target appropriate skills of the child. Auditory feedback loop establishment by imitating the child's response, and hence encouraging the child to listen their own verbalization. The guide and coach parents to help their child self-monitor spoken language through listening. The parents models correct or appropriate speech to the child. This in future will help child for independent verbal communication with the minimal need for clarification. Administer ongoing formal and informal diagnostic assessments to develop individualized auditory verbal treatment plans to monitor progress and to evaluate the effectiveness of the plans for the child and family. The therapist uses a battery of test speech articulations, receptive and expressive vocabulary, and development of cognition. Promote education in regular schools with peers who have typical hearing, and with appropriate services from early childhood onwards. The therapists ensures the child's development needs are met in the mainstream school environment. So AVT progresses through 4 levels of auditory skills, such as detection. That is, the beginning stage is the ability to determine the presence or absence of sound. Discrimination, it's ability to perceive differences between sounds. Identification is the ability to label what has been heard by repeating, by pointing on to, or picking up the object representative, the words or sentence or environmental sound perceived. Comprehension, the ability to understand the meaning of connected language. The listening environment, AVT encourages the maximum of hearing in order to learn language and stress listening rather than watching. Listening environment can be enhanced by following conditions. Like parents or therapists sitting beside child on the side of better ear, speaking close to child's hearing, and cochlear implant microphone, speaking in quiet voice at a regular volume, minimizing background noise, using speech that is repetitive and rich in melody, expression and rhythm, using acoustic highlighting technique to enhance the audibility of speech spoken language. Auditory verbal techniques such as acoustic highlighting, auditory closure, recording, asking what did you hear, providing alternatives, pausing in between, repeating a previous strategy, waiting until the child responds, rephrasing if the child is not understanding the first sentence, labeling by category like animals, fruits, etc., asking for providing a definition, um, and changing the task from open set to closed set, providing rhyming words, suggesting opposites, providing a visual cue, and putting the stimulus back into hearing, moving closer to the child, directing the child to listen closely, repeating part of the story message containing the answer, using the often misunderstood technique and the hand cue. Next is Erber's method. This approach is based on the analysis of child's auditory perceptual abilities with the use of Glenn-Donald auditory screening procedure, GASP test. Two factors will be taken into account: complexity of the stimuli, like speech elements to connected discourse, response form such as detection, discrimination, identification, and comprehension. So when the skills are achieved and the training is outlined, Alper stated that there is no need to follow developmental stages. Instead, he proposed 3 styles differing on specificity, direction, and complexity. 3 general auditory training methods. First is natural conversational approach with general consideration to the environment and context. The clinician or teacher speaks with the child in natural ways without any visual cues. The task may include like sentence comprehension. Next is moderately structured approach. This includes closed set auditory identification task, but will be related to speech developmental procedures and comprehension task. Practice on specific tasks. This includes selection of specific auditory stimuli and prepares materials needed, and depending upon the child's auditory need, delivers the approach. Attention is paid on the listening skills. Next is group listening training. Like group based therapy will also be provided individuals with hearing impairment. However, it is necessary to consider that members of the group be homogeneous in terms of listening and language age or receptive and expressive language skills. Here the 5 to 6 members are included. The children are made to sit in semicircular fashion, and therapist sits in front of them, and background noise will be minimalized. Activities should be such that children learn turn taking, habit of listening to others, and one child speaks at a time. So games and other creative activities can be included in groups sessions. Advantages of this group therapy is children learn turn takings, as I already mentioned, and parents have the advantage of learning activities and strategies from each other. It helps to train the children for further educational placements or integrated education. However, an individualized attention cannot be given in group therapy. So it is difficult to maintain homogeneous groups because each child would have different strengths and weaknesses. For children with different listening skills, activities should be selected in such a way that it can be fitted to all children, but the target response will be based on their listening abilities. Group therapy can be defined as a treatment procedure that includes a small group of people guided by a professional with expertise in the group of intervention. Objective of this group therapy is to promote psychological and social growth, and it reduces psychological problems such as cognitive exploration, behavioral and affective interactions among members, and within micro and mesosocial contexts. So limitations are it includes middle class values and are inaccessible or irrelevant to lower socioeconomic classes. Time is one paced and it goes fast. Focuses on the use of technology used than psychosocial adaptation. There is a conflict between fulfillments of either individual or group needs. Change is seen less if there is a small group. And criteria is based on age, need and interest, and communication ability and degree, and natural nature of hearing loss should be similar. Next, group listening activities for children with different listening skills. Awareness. One pictures associated with link sounds will be pasted on the wall, and child is to hear the sound and tell it loud and point it out. But now awareness is not taken as a separate goal because child is taught concept wise. So identification, awareness are worked together. Next is discrimination. Gross discrimination, that is intensity. Play activity in which two balls will be kept in front of children, and the child is instructed to put ball in higher ball into the higher bowl. If the sound is louder, and to the lower one is lower if it is softer. And duration. Line drawing activity can be carried out, like short line and longer line for the shorter sound and longer sound respectively. Next is identification. Using food items in play activity. Placing order in hotel can be carried out, like children will opportunity to become a waiter and the clinician to be the customer. And animals, play activity of searching animals escaped from zoo can be carried out. Cages can be prepared, and each children is instructed to put the animal in the cage which they have searched. Or the cups can be used, like where the stickers of animals are sticked onto the cups, and child have to identify the missing animal where the cup is covered with another cup, empty cup. Next is comprehension. Child is made to tell a small story, and random questions can be asked to children by children. So second is preparing for a festival, so each child will be asked to help in the preparation. Through this activity, children can be given a simple command to follow. In cognition, challenging situations can be described to children, and each child is encouraged to give alternatives for that condition. Example, like raining. When it is raining, what would you do? Like that. Next is computer assisted programs in oral rehabilitation. For example, one is Story Weaver, David, that is dynamic audio vision interactive device. Conversation made easy. Casper sentence, that is computer assisted speech perception testing and training at sentence level. Computer assisted tracking stimulation, computer assisted speech training, listening and communication enhancement, aerobics for CAPD. Story Weaver, child creates story based on therapist instructions or comprehension. Make child to narrate the story to improve verbal skills. Child selects pictures and builds story on his own, improves his creativity. Next is David, dynamic audio vision interactive device, that is National Technical Institute for the Deaf at Rochester Institute and Technology. In sentences are verbally presented by software. Child has to either select from choice, type the content word, or type in the whole sentence depending on the difficulty level. Sentences can be repeated. Responses are documented in the software. Conversation made easy. Three versions are available for adults and teenagers, for children with high level of language skills and for children with low level of language skills. Three kinds of exercise in each version. One is sound, word and phrase discrimination and identification. Animations are used in this contest, and sentence recognition. Animated figure speaks out a sentence and child select the sentence by clicking one out of the options. Next is speech reading practices. Practices are related to contexts, that is class for children and visit to a physician for adult. Simulates a real world environment. Compensatory strategies are also taught. Child can request for changes in environment for his ideal listening. Next is CRASPR sentence, that is computer assisted speech perception testing and training at sentence level. Multimedia program by Dr. Arthur Boothroyd 2006 introduced this test, and he used sentence level speech perception training and testing. 60 sets of CUNY, that is City University of New York sentences are used. And he presented in hearing alone, lip reading alone and in combination of both. So scoring is based on sets of 12 sentences. Responses are stored, used for testing and training, self-administered or with the help of a clinician. Next is computer assisted tracking stimulations developed at Central Institute of Deaf, and it is updated by Dr. Harry Levitt. Speaker says a sentence or a phrase and listener repeats it. If it is correct, moves to next sentence. If it is wrong, repeat the same sentence. Software helps to store the scores and monitor the program. Next is computer assisted speech training. It is developed for the rehabilitation of individuals with cochlear implant. Electric stimulation is a new experience for acquired hearing loss. Hearing is a new experience for individuals with congenital hearing impairment. Provides wide range of closed set discrimination and identification task with auditory verbal materials. Can mimic the realistic environment. Noise mixers and telephone simulators are used. Different difficulty levels are available and changes are automatically based on client responses. User friendly and easy to use. Stores clients information, test results, testing and training date. Listening and communication enhancement. It is a home-based and self-paced adaptive auditory training program to improve listening and communication skills. It increases auditory memory and speed of processing. DVDs and online versions are available to use this test. And three categories are include cognitive skills, communication strategies, perception of degraded speech, that's time compressed or in background noise. So objectives of this test is get patient involved, make the patient recognize difference between hearing and listening, build confidence, provide communication strategies, reduce unnecessary patient visits. Next is aerobics for CAPD. For developing auditory and reading skills, it focuses on phoneme perception, listening skills, vocabulary development, fluency and comprehension. Advantages are sounds can be recorded and played back. Recorded sounds can be associated to pictures and animations. The repetition of stimuli is easy and hence easy to give intense listening practice. Kids will be excited to control things happening on the screen. Therapists can demand verbal output from child, which software to use, what do you want to play, etc. Provides pictures, speech, animations, etc. and make the activity more pleasant. Softwares allows integration of communication skills and academics. It stores students' response, allows to monitor home training progress, and most programs incorporate interactive training, not possible with other audiovisual recorded materials. Students can proceed in his own pace. It can provide different programs at home itself, transportation to be reduced, cost effective, etc. Thank you for joining the webinar.